Hello and welcome. We will start from where we left in the last part. So, let's start. The learning objectives are shown. Please take a look. Before we discuss the drugs, let's recall that active transport needs energy to transport a molecule against an electrochemical gradient. This is found in all tissues. It could be primary active transport if the transporter itself is hydrolyzing ATP to release energy needed for the transportation, such as sodium-potassium ATPase. In contrast, the secondary active transport operates on the gradient built by the primary active transport, such as sodium-calcium antiport in myocardial cells. An analogy is the system of gears as shown here. This slide schematically shows how normally a primary active transport moves sodium and potassium in opposite directions, while a secondary active transport moves sodium inwards and calcium outwards, completing the rotation of sodium and preventing buildup of calcium inside the myocardial cells. Now, digoxin inhibits this Na-KATPase pump. As a result, intracellular sodium is increased, reducing sodium-calcium exchange, thereby raising intracellular calcium and strengthening myocardial contraction. Thus, the main effects of digoxin on heart include a positive inotropy, or increased contractile force, and a negative chronotropy, or reduced heart rate. This negative chronotropy is partly via drug-induced vagal stimulation, causing a parasympathomimetic effect. Digoxin is notorious for its low safety margin. Adverse effects include narrow therapeutic index, causing arrhythmias such as premature beats, big MNE, and specific electrocardiography changes. The parasympathomimetic effects may lead to nausea, vomiting, and electrolyte disturbances. To simplify understanding, let's consider the cartoon character Popeye the Sailor as the failing heart facing a heavy task in a time-constrained situation. Scenario 1 shows Popeye as having difficulty to finish the heavy task that should be completed in a given time frame. This is similar to an untreated heart failure, where preload and/or afterload is leading to a low ejection fraction in its symptoms. Scenario 2 shows that if we reduce the load, then Popeye is able to carry out the task. This is similar to when we take some load off the failing heart by giving vasodilators and diuretics to reduce preload and afterload, easing the burden on it. Scenario 3 shows that Popeye is somehow able to carry out the original task if we remove the condition of time. This is similar to treatment of a CHF patient with beta blockers, which reduce heart rate, allowing better filling and efficiency. Scenario 4 shows that Popeye consumes his spinach tonic to increase power and performance within the same time frame. This is similar to using inotropic agents to support cardiac function in CHF. So far our discussion suggests that drug therapy improves cardiac function. But does that mean that all drugs do it to a similar magnitude? In other words, do all those drugs have a similar impact? The simple answer is no, of course not. This slide schematically shows how various drugs impact the restoration of deteriorated cardiac output to a condition as close to normal function as possible. Note that arterial dilators include hydralazine and nitrates such as nitroprusside. The vasodilators include nitrates like glycerol trinitrate and isosorbide. This is a summary of drug use in CHF with reduced ejection fraction. The most important thing to remember is to treat the cause, support the heart, block the overreaction. Take a closer look. This is about the drug use in CHF with preserved ejection fraction. Take a closer look. This diagram refers to the one shown in the beginning of the first part and adds various drugs helpful to treat or correct the underlying pathophysiology. Take a closer look. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!